let's move on. Our last speaker for this session is Thierry Nyatanyi from the COVID-19 Task Force Africa CDC. Thierry, are you on?
My name is Thierry Nyatanyi. I'm a senior advisor to the Ministry of Health in Rwanda for COVID-19 response. Briefly, I'll take you through the lessons learned to reinforce the relevance of One Health principles. And by doing that, I'll take you through our experience with the COVID-19 response. So briefly, this is how my presentation is structured. We'll have a review of the existing frameworks. I'll describe the government-led coordinated response to COVID-19, then also talk about rapid scale-up of SARS-CoV-2 testing, technology surveillance, and learning to improve health system resilience. Briefly, these are existing frameworks that we know of to support countries responding to infectious disease threats. There's the international health regulations. We have the Aquatic Animal Health Code, Terrestrial Animal Health Code, and also the tripartite. And from these, we have a lot of frameworks that have been developed, including the IHR monitoring framework, the JEEs, PBS pathways, and the Global Health Security Agenda. But all these frameworks allude to one thing: how do we prevent the spread of infectious diseases without interference with international traffic and trade? That's IHR Article 2. The same applies for the OIE Terrestrial Animal Health Code, same for the OIE Aquatic Code. So amidst the COVID-19 pandemic, how have countries responded? So briefly, I'll give you an example of how in Rwanda, we've really struggled to find some guidance in relation to. So as I was saying, immediately after 6 days after having the first case confirmed, which was an imported case, the government decided to close all borders, land crossing borders and the airport. And later on, because Rwanda is a landlocked country, we still allowed travel, trade to go on from neighboring countries. So that also was a huge problem because most of the truck drivers that crossed into Rwanda, we started testing them, and most of them were turning out to be positive. So there was a big meeting of heads of state within the East African Community region that decided whereby each country could be able to access, test results from, another country, meaning that if a truck driver would come in from a neighboring country, we would be able to those test results that learn from the COVID-19 experience, whereby regional economic blocs get together to support travel and trade, to make sure that there is continuity of trade amidst a pandemic. Plus other measures that we took, reopening of the airports and also reopening of borders. But clearly there wasn't any sort of international guidance or sort of a framework that could define. So we were struggling to come up with some solutions based on how the situation evolved. And as you can see, we still had a lot of imported cases. So again, as some of the previous speakers mentioned, I think there is a need to review some of these frameworks moving forward. Over. Next. So prior to the COVID-19 pandemic, we built our experience of managing public health threats, a long time. First during the 2009 pandemic, influenza H1N1, and then the 2014 Ebola outbreak in West Africa. And all this culminated into the implementation of One Health as an integrated approach. And this is where we had senior leadership really invest a lot of resources and time to set up a framework, a mechanism that can be able to address some of these challenges, given the fact that Rwanda is neighboring to DRC and we have Uganda. So these are countries that, as you may all know, every after 2-3 years, we have, viral hemorrhagic fever outbreaks. And there's a lot of travel and trade between these countries and Rwanda. So next. So briefly, I would say that this is not the coordination mechanism that was already in place. Of course, as I said, we had a One Health coordination mechanism, but given the fact that really COVID-19 had a huge impact, across the globe, there was a mechanism that was set up that was really high level, led by the Prime Minister's office. As you can see, it was set up 8 days before we had the first case of COVID-19. And on top of that, this coordination mechanism was decentralized later on, as I'll demonstrate during my presentation, after sitting down and revisiting some of the measures that we've been using to also part advisory team, which was composed of academic institutions, development partners, which was really very, very important in sort of like bringing together all these people to sort of advise on response measures and mechanisms. And we had all these components of epidemiology and surveillance, logistics, risk communication, and planning. So this is sort of the kind of coordination mechanism that was set up, chaired by very high-level decision-making people, ready to fast track related to next. So as I said, high-level political commitment is very, very important. So probably in Rwanda and there is a need for consistent and unified messaging for adherence to COVID-19 mitigation measures. So things that have to do with social distancing, things that have to do with hand hygiene. So these are some of these pictures are, these are public places. This is a common bus stop that usually overcrowded, but as you can see, people are practicing social distancing, and also you can see that people are, public hand hygiene facilities, and we've learned that, enforcement of some of these measures really goes beyond the public health scope. The public health fields, vet fields, it has to do with local government. It has to do with other sectors that are familiar with dealing with with the masses. So another important thing is free services to COVID-19 testing, quarantine, and treatment. This proved very, very effective in terms of, curbing the spread of the infection. And of course, building public trust, because some of these measures required lockdowns. So, in order to do that, you really need to have the buy-in of the people. And without a government that they trust, then this becomes very, very complicated. So a lot we did along this is, of course, decentralization of COVID-19, supporting local manufacturing to boost import gaps, because we had issues of, truck drivers that tested positive, and they had to be quarantined and isolated, and so that delayed the imports that came into the country. And also, most important, production of basic essential protection equipment, such as face masks, hand sanitizers, etc. And also fast-tracking vaccine deployment. So I would say here that some of the lessons learned is, of course, there are some things we hadn't thought about, when we're really putting together the One Health coordination mechanism. Some of these issues really, we hadn't thought about them until COVID-19 struck. It has to do with trade. It has to do with the ministries, different sectors, including the ministries of economy and planning, the ministries of trade, the tourism sector. So it has to do with everything that that touches on the lives of the different people. Next. So as I was saying, following some of the epidemiology indicators, some measures have to be implemented. And this is an example of the lockdown of Kigali, which is the capital city of Rwanda. So it's not far from, I think it was 3 weeks ago, where we had a surge of number of cases of COVID-19, and the decision was made to, for Kigali to be under lockdown. And as I was saying, this requires effective coordination and effective management, because a lot has to be done in terms of messaging, convincing the public about the importance of having the lockdown. And of course, as you can see, eventually it yields results, because 14 days after the lockdown, we started seeing the number of cases decreasing. Next. Yeah, something also I wanted to highlight is the national scale-up of SARS-CoV-2 testing. So prior to the SARS outbreak, we only had, I think, 1 or 2 machines that could do a period of 9 months. This capacity has been built, across the country. So we've built this capacity within a short period of time, and I would say again that it's thanks to the leadership that really fast-tracked in terms of fast-tracking procurement of these machines, fast-tracking procurement of reagents, training people on a large scale that will be using these machines. And not forgetting also that on top of these machines and on top of PCR testing, we've also adopted rapid testing to really increase on the number of people that we're testing, so as to even reach the WHO requirements, which are at least testing 3 people per 1,000. And to some extent, we've managed really to scale up our testing capacities. Next. Yeah, important also, I wanted to highlight the importance of research. This is a paper that we published some time back. And as you can see, by early May, we had submitted the paper for review, but which was really, for us, research institutes, the Mathematical Institute of Science, the University of Rwanda. So to really optimize on SARS-CoV-2 testing, Rwanda is a resource of the resources. So we have this is an example of pool testing, whereby we could do testing from we could pool samples by 20. Right now it's by 10. Of course, it's in low prevalence countries. So right now I think the prevalence is a bit higher. So we're pooling by 10. But it really proved very cost effective, given the fact that the resources that we might have used to test 20 people, we're using them to test, to test 1 person, we're using these resources to test 20 people. And, this is something that we've learned along the way. How do we reach out to some research institutions? How can they work with people who are at the forefront to really come up with innovative ideas? Next. Yeah, and the lab diagnostic testing, as you can see that we've had, using some of these approaches, our testing capacity has really been very high. We're conducting 100 positive case confirming testing around 4,000 to 5,000 samples. So, very impressive. The scale up of some of these innovations, pool testing, to test as many people as we can using limited resources. Next. So for epidemiology surveillance and capacity indicators, these are some of the indicators that we are using to track the incidence of COVID-19. And these indicators are really unique. I think they're similar, somehow similar to some of those that were shared by WHO. And the uniqueness of these indicators is that we came up with some solutions to be able to track this at a country level using, geolocation. The next slide, next please. Yeah, so for AP surveillance, the concept architecture is based around using surveillance data, testing data, and then using information for administrative boundaries so as to really track some of these indicators. So for all the administrative boundaries, we know the number of people that live within those boundaries. And so it's very easy for us to track some of these indicators. If you have the denominator, X people tested from this village, X people turned out to be positive. So you can easily tell that the incidence really is leaning towards the red. If it's above 5 or if it's less than 3, then that's fine. So we've been using this platform, the Arcgis Enterprise. And again, as I say, I'll come back to this innovative solutions, but also using the local capacity. So this is all done by young engineers that, prior to COVID-19, we didn't, we didn't realize that they did have these skills. So this is really important. And at the end of the day, this information is shared by, everyone has access, of course, the decision makers, the public, analysts, most important, of course, epidemiologists who really need to make sense of this information to devise preventive and response strategies. Next. Yeah, so this is an example of the Arcgis Dashboard. So this is for anyone who has access to the Ministry of Health link. So this is for public consumption, but of course, for epidemiologists and decision makers, they might have access to more advanced information, breaking down and knowing exactly how. Hello?
We can hear you.
Yes. Yeah. So making sense of all this information and relating them to the surveillance indicators. So which is really very, very important. And this is the information that actually the government has relied upon, to come up with some stringent measures, especially, determining which areas have to be locked down, where to emphasize communication and awareness, where to emphasize, probably social distancing measures. Next. And also, as I said, we've developed and people have come up with a lot of innovative ideas, as I said earlier on, especially for contact tracing. We are using specific apps that have been developed locally here in Rwanda. And this is really interesting and impressive. And again, as we keep on thinking about the One Health, how to rethink about One Health implementation. I think innovation is one of the key areas that I think people should, come up with some interesting ideas to see how we can use, this experience from, Rwanda or any other countries. I'm quite sure there are so many innovations that have come up amidst the COVID-19 pandemic that we can leverage on to improve One Health. Next. I would also want to talk about the health system resilience. So there is the WHO guidance for conducting intra-action review. So previously, we were more familiar with after-action reviews. But with this document, it really proved to be very, very important. given the fact that, you can review, some of the best practices while you're still, responding to an outbreak. Previously, with the after action review, one had to wait for the outbreak to end and then review. So we have conducted this, and back in November, when we started having again a surge in an increase in number of cases, and it was really very helpful, especially given the fact that it helped us to update and validate the COVID-19 strategic preparedness and response plan. But it also gave us some insights on some of the gaps, which were really related to the decentralization of COVID-19 response along all the aspects of response, surveillance, case management, risk communication, coordination, especially for case management. Our health facilities were being overwhelmed. So we had to adopt the WHO guidance of, implementing home-based care. And that required really the support of the entire healthcare system, which is using community health workers, as people who could help us implement the home-based care approach, so that we can decongest our health facilities and assure continuity of health services. So I would say that, again, this is something that we need to think about, interaction reviews. How do we come up with some specific metrics, One Health metrics, that we can use along the way while responding to an outbreak to improve response. Next. Yeah, lessons learned is capitalizing on the government-led approach to COVID-19 response to institutionalize One Health. So the high-level decision-making, dedicated commitment, setting the agenda. So the lesson learned here is that once there's that government ownership, and if government decides to set the agenda, then there's that ownership, and probably it can lead to rapid implementation of One Health within a country. Of course, we've been struggling a lot with coming up with emergency operation centers, given the fact that they're bringing a lot of sectors. Of course, there is a lot of friction, tough wars, but of course, based on the momentum that COVID-19 has created, I think it's high time to really see how we can fast track legislation and even mechanism to operationalize EOCs and institutionalize One Health. And of course, with this, I think most countries have, including Rwanda, we really didn't get the best scores in terms of during the JE evaluation in 2018 along the EOCs. So this will be an opportune moment to really improve on these scores, but of course keep building on this momentum. Domestic investments for health system strengthening. Yeah, it's still a big challenge. We have all these frameworks, the GHSAs, the JEs. Previously, we had IHR, but clearly, without health system strengthening, then it's very, very difficult to be able to have positive. So I think some of these investments, are coming in from, development partners, not really from within government. So government owning this and committing to investing in health systems, we believe of course, leveraging existing frameworks to ensure continuity of to find solutions on how there could be continuity in travel and trade. So we can capitalize on that. We can see how this is done to really inform decisions around, and of course fostering homegrown solutions. As I said earlier on, we didn't know that we had the capacity, but with time we're realizing that we have local capacity to do this. And of course, investment is really important, given the fact that we've learned that with local capacity, local research institutions are also capable to provide solutions to existing challenges. Next. Yeah, so lastly, I would want to end with a quote from Winston Churchill: "Never let a good crisis go to waste." Thank you so much.